Okay, now let's consider the AOGD Bulletin number 2024. So I'm not going into very details of SLE because you learn in your notes, class notes and all. So let's learn the what highlighted points here. Okay, so diagnosis and management of SLE. So here, see, SLE is something like you have genetic, environmental, hormonal factors. Okay, environmental factors include infections, ultraviolet radiations. They can trigger SLE. Right. So there is musculoskeletal and mucocutaneous involvement. Investigations is ANA, anti-DS, anti-Smith, complements, CBC, urine test, tissue biopsy, organ-specific imaging should be done. Okay, anti-antigen antibodies and antiphospholipid is also done. So very important is highly specific is anti-DS DNA, most specific is anti-Smith antibodies. Okay, then coming to Euler classification, I will concentrate on this now because it's repeated question. You should remember and should write the points. Although I don't know why these kind of questions are given theory exams. So just by heart this, but for by heading also you should remember easy. So I'm telling you this, okay? So first thing when a patient came to you and you're suspecting SLE, then you'll do an entry test that is ANA antibodies. ANA antibodies are more than 1 is to 80, more than 1 is to 80. Okay, on Hep2 cells or equivalent positive test, any other test which is equivalently positive, then she passed the entry criteria. Then if it is absent, it is she's not SLE. If it is present, then she is not SLE. She should have the additional criteria. Then only we can find out that she is SLE. Okay. So first additional criteria is all that there are 10 criteria. How many? 10. So in these 10 criteria, at least one clinical criteria should be present. At least one clinical criteria should present, and 10 points should come. All the points which, if we add, 10 points should be present. Okay, and criteria need not occur simultaneously. For example, if she is having delirium once and she's having pleural effusion after 3 months, okay, it's okay. No need to occur simultaneously. Okay, and in these are all domains. 10 domains are there. In these domains, there are different parts. All if in one domain, for example, if you see this one in delirium, psychosis, seizures, if delirium is also there, in seizure is also there, then you will take the highest weight criteria. You'll take the seizure point. Okay, that's it. Now see, each and every part of the body is involved in SLE. Okay, so first is constitutional. What is constitutional? Like it is present in everyone. Every disease you'll have this kind of symptom. What is that? Fever. So minimum point you'll give for fever. What is the minimum point in this Euler criteria? Two. 2 points is the minimum point. So first is constitution, fever. You'll give 2 points. Second is hematological. You know now in blood what are the three cells? Leukopenia, thrombocytopenia, hemolysis. That is anemia. So leukopenia is something three. That is thrombocytopenia and anemia or hemolysis will give four points. Done. That is about blood. Coming to brain. Now we are now coming to brain. Okay. In brain you have DPS public school. What is DPS? Delirium, then psychosis, then seizures. Okay. Delirium, psychosis, seizures. In this you'll give 2, 3, 4. 2, 3, 4, nahi. 4 is absent. So you'll give 2, 3, 5. Where is 4? 4 went to blood. 4 went to blood. What is blood? I don't know, thrombocytopenia hemolysis. It will come 4. So 2, 3, 5. DPS. 2, 3, 5. Done. Now coming to skin. Skin is pyara. Hum log ko be like skin, right? So skin you should be even tone of the skin. So all the ads and advertisements will get even tone aana hai. So even is number is something like in skin. So first coming to top, alopecia it is 2. Coming to down, lips. Okay, lips. This is alopecia and this is lips. Lips or oral ulcers you have 2. Then you have this rash, discoid rash and all, you have 4. Then acute cutaneous lupus everywhere. I saw one patient in ANC. She came at, I think, some 32 or 30 weeks she came and she delivered by cesarean section, previous cesarean section with SLA. She had a very bad rash and she's like, she's a known case of SLE and she's not taking any medications. In pregnancy also, she's not taking any medications. She came with rash, very classical rash on legs, hands, face, everywhere. And she's chubby also, so we can see the rash classical on her legs. Okay, so for that acute lupus, we'll give 6 points. Okay, Next is that is about mucocutaneous. Now coming to serious matters, serious things. That is cirrhosis. Okay, in cirrhosis you go for pericardial and pleural effusion is 5, and acute lupus 6. Then coming to joint involvements, you have 6. Renal, you have proteinuria 4. Class 2 and 5 is 8, and class 3 and 4 is 10. See, 5 is 8 only, but 3 and 4 it is 10. I don't know how to remember this, but yeah, what kind of score is this? Just remember, yeah, remember. Okay, class 3 and 4 is 10. See, my sincere advice for you people is before going to exam, before going to theory exam, for example, in your DNB exam, these kind of questions are expected as it is SLA in pregnancy. So this is expected in paper 2, and this is a research advances also. It can be explained paper 4. So before going to exam, like after writing the exam, you come back, na, once take this table and or just mark this point in my video, and once you revise this and you'll print in the exam, no matter what, no one will be asking you in future what is that score for renal biopsy class 5 in Euler score. No one will ask you. Okay. In your no patient will be asking you. Even patient comes also you'll refer to the score. So but for theory and getting marks you should remember. Okay. See it's not that waste to remember these things. It indicates the seriousness of the reports. For example, the patient which I told, na, she came to me, I told, right? If that patient came with the joint involvements, joint pains, then her score is 6. So I need to remember 6. 6 is very near to 10, right? 6 is very near to 10. So any fever is can be present. All obviously antibodies will be present in her. So her score will be more than 10, obviously more than 10. So this is a general idea for the sports. It is not that waste, but exactly to write it is 2, to write it is 5, it is very difficult, I feel. So not to discourage you people, only advice, pure advice is for DNB theory exams, just revise it before the exam, these tables. Okay, just revise it, okay? Now coming to APLA. In APLA antibodies, anti-cardiolipin, anti-beta-2 glycoprotein, lupus, all is 2. See, they give so much hype for this antibody. Score is only 2. Fever is also 2. Antibodies also 2. Come on. Okay. Coming to complement proteins, if C3 or C4 is low, then it is 3. If C3 and C4 is low and both are low, then it is 4. Okay. Antibodies, I told already, na, the specific antibodies, Smith and DNA is 6. Okay, so 6 is something like acute lupus, acute pericarditis, joint involvements, and antibodies are 6. I think you remember easily. Okay, after this video, I think you can write some more the other things. Okay, so I'll just revise this. Fever it is 2 points, then blood 344, then DPS public school 235, then mucocutaneous all are even 2, 2 and 4 and 6, cirrhosis pericarditis 5 and acute pericarditis 6, musculoskeletal joint form is 6, renal proteinuria is 4, renal biopsy 2 and 5 is 8, 3 and 4 is 10. Then antibodies are 2, complements C3 or C4 is 3, and C3 and C4 is 4. Then specific antibodies like DNS Smith is 6. Okay. So total score after doing this total score if it is 10, then the criteria is fulfilled. Okay. Then it is classified as SLE. Sorry. Okay. So now see main important thing in this question if people get SLE in pregnancy, perfectly you should write this in one page that SLE versus preeclampsia. This should be written. Okay. See, first antibody levels. ANA antibodies are small percentage positive in preeclampsia, but DNS antibody that is specifically it is negative in preeclampsia. Complements are low in SLE only, not in preeclampsia. Cytopenias are also more common in SLE. Organ involvements like kidneys, brains, heart in SLE, whereas in preeclampsia, kidneys, liver, and placenta is involved. Okay. So if you write this table now, you'll get good marks. Good marks like onset. And SLE at any stage of any pregnancy or before pregnancy also you'll get. Preeclampsia is after 20 weeks generally. Symptoms are say mostly like fever. Fever is fatigue, fever, joint pains, kidney problems, and neurological symptoms. So remember that ULR classification, then you'll write the SLE. And preeclampsia is hypertension, proteinuria, edema, headache, and visual disturbance. Laboratory, all the antibodies here, you have proteinuria, enzymes are affected, thrombocytopenia, hemolysis, LDH is elevated. Treatment is immunosuppressive corticosteroids, anti-malarials, your antihypertensive, bed rest, and delivery will do. Okay, so SLE in pregnancy, it can lead to flares and organ damage. So whatever kind of overall management of SLA, I'm telling you now. You can give non-pharmacological measures like you should stop the triggers to sunlight, anti-malarials like hydroxychloroquine, 200 to 400 milligram per day is given, corticosteroids given prednisone 2.5 to 7.5 milligram per day, steroid-sparing immunosuppressive therapies like cyclophosphamide, mycophenolate, mofetil, azothioprine, classes inhibitors, and biologicals like anti-PAF, belimumab, anti-interferon receptor. Uh, Aniflorumab, okay, belimumab, aniflor, anif, anifrolumab, okay. Mm, so disease monitoring is important. There is a SLEDI classification. So you should do all the laboratory testings and all. Specifically, goals should be treat and target that goal. Okay. So now very important and topic of discussion is SL in pregnancy management. That is SL in overall management. Here, SL in pregnancy management, you'll give hydroxychloroquine, low dose corticosteroids, immunosuppressors mm, can be given, but only azothioprine and calcineurin inhibitors are given. Not all immunosuppressors are better. Okay. Then conclusion is important. SLE affects pregnancy outcome both maternal and fetal. Okay. Coming to obstetric management, that is a continuation part. So here. Hydroxychloroquine is given, and yeah, preeclampsia with SLE is almost 60 to 30%. We'll start low dose aspirin. Everyone will ask what is low dose aspirin. Then you should specifically say these values, not 80 or 75. Okay, 81 to 162. Okay, better write like this: 81 to 162. 12 to 16 weeks and up to 36 weeks you'll do. It reduces auxiliary risk of preeclampsia by 2 to 5%. There is neonatal complications like abortions, preterm, FGR. Neonatal lupus occurs mainly positive with antiviral and antibodies. Congenital heart blocks is also seen. Okay, I told one example, right? In that female, we did fetal echocardiography also. Luckily, the fetus has nothing because she didn't use any medications. Yeah, I don't know. Okay, and she's a known case of SLE. It's not like she got in pregnancy. Then preconception care is also important. Uh, During management, maternal monitoring should be enhanced. I see in heart disease of pregnancy, you'll ask her to review in cardiologist depending upon the WHO classes of heart disease, right? In that way, SLA also in pregnancy, she should review with the rheumatologist in each once in each trimester. She should refer. She should go and visit the rheumatologist. Okay, and detailed examination should be done, including skin, lymph nodes, respiratory, cardiovascular, abdominal, musculoskeletal, neurological symptoms. Even if you don't remember this, remember you are good. So laboratory, you'll do the CBC, you'll go for KFT, LFT, erythrocyte count, erythrocyte sedimentation rate, anti-DNS antibodies, complements. Okay, complements are usually high during pregnancy, but if there is disease flare, there is mask the drop because already they're high. If they drop also, they'll become normal. Okay, they'll mask the level of this. Fetal monitoring also should be done. Ultrasound. Okay. In third trimester, every month ultrasound they should be taken. Okay. Medication management should be given. Okay. See, commonly, if SLE non-pregnant female, you'll give cyclophosphamide, methotrexate, leflunomide, mycophenolate. But in pregnancy, they have teratogenic effect. So before conception, they should ideally stop. Okay. This lady in my example, she is not taking medication. Luckily, she didn't use the cyclophosphamide and all. Healthy baby came. Coming to common drugs in SLEs, hydroxychloroquine is used. Okay. NSAIDs can be used, but it should be stopped after 20 weeks because of risk of oligo. It should be stopped after 30 weeks because of risk of premature closure of PDM. Okay. See, glucocorticoids are also there are two types. Generally, will give for lung development is fluorinated. Non-fluorinated can also be given. Okay, and other drugs like azathioprine, sulfasalazine, 2 milligram per kg body weight. Cyclosporin is given. But if you give cyclosporin, you should monitor the blood pressure and KFT. Tacrolimus is given. It is used for mainly tacrolimus is used for lupus nephritis. Remember this part. If lupus nephritis, what is the treatment of choice? If you have cyclosporin, azathioprine, tacrolimus also better go for tacrolimus. Okay. If there is SLE flare, what you'll do? There is mild joint pains, mild oral ulcers. What you'll do? Then you'll give prednisone 20 milligram per day. Consider the azathioprine. If he is having moderate and severe arthritis, discoid lupus is there, and cytopenia is there, then what you do? Again, you start prednisone 20 more than 20 milligram per day and start. Don't consider start the azathioprine. Now coming to severe flares. What is severe flare? Remember Euler, kidneys, heart, lungs, hematology, central nervous system, Aplas syndrome. Then you start prednisone more than 20. IV treatment of methylprednisolone is given, azathioprine, and you start other agents like cyclosporin, IVIG, belimumab, anakinra, aculizumab, these things. Okay. In breastfeeding mothers also you can give hydrochloride, which is safe. Okay. Uh, low molecular weight heparin should be given in patients with SLE because there is a plus syndrome in SLE of 25 to 50% coincidence. So low molecular weight heparin 1 milligram per kg body weight is given once daily. Contraception is best is Marina, and POP pills can be used. Other OC pills, IUDs are not suitable. Okay, preeclampsia is most common complication as well. Next is thrombocytopenia. Platelets is normal is 1.5 to 4.5. If it is less than 1.5, it is thrombocytopenia. Okay. Generally, gestational thrombocytopenia is seen in pregnancy. Okay. Oral prednisolone can be given. See, um, as a gynecologist or big upcoming gynecologist, you should remember when to panic. Okay. See, generally, platelet count should be more than 1 lakh. If it is 90,000, also should not panic. Okay. You should not panic. In gestation, there is a gestational thrombocytopenia. Okay. Rare case only will become 50,000 to 80,000. Mm-hmm. Okay. Then also you start oral prednisone and you can continue the pregnancy. There's nothing like that. Okay. And thrombocytopenia is seen in case of eclampsia, preeclampsia also. We'll test the platelet distribution width as well. And dexamethasone and magnesium sulfate to prevent seizures is given. Within 2 to 3 days after delivery, the platelets become normal. Thrombocytopenia is seen with AFLP. Thrombocytopenia is seen with TTP and HUS. ITP. Thrombocytopenia is seen with ITP because anti-platelet antibodies are seen in them. Okay. Even vaginal delivery is possible more than 50,000. Why you're getting panic in 90,000 platelets? Don't be panic on that. Okay. Repeat platelets. In fact, you should repeat the test again. Okay. Um, then oral corticosteroids is associated with cleft. See, oral corticosteroids I'm telling you to give. So giving that there is a risk of cleft palate, preterm delivery, gestational diabetes in this cases. Okay. Then family history of thrombocytopenia should be ruled out. Treatment is um, platelet count of more than 50,000 is desirable to have a delivery. Below 50,000, then rule out the ITP. Okay. Then platelet-rich plasma can be given in them. Nothing more. HIV in pregnancy. See, once you get a question on HIV, if you write point wise, like first family retrograde, then subfamily lentiviride. If you write in that way, you'll get good marks. Okay. So, so globally, there are 37.6 million people living with HIV, and 1.4 million people are females with pregnancy. Okay, 37.6, 1.4 million. In India scenario, it is 0.22%, prevalence is 0.22%, and India is the third highest burden HIV in the world. Okay, heterosexual is most common cause. Already I told you already know people, viral HIV goes and bind the mucosal dendritic cells. These dendritic cells have CD4 T cells. Um, CD4, why only CD4? Because it serves as a receptor. It is like come on in that way. So virus go and sits on that. Once the CD4 lymphocyte is affected, it affects both cell immunity and humoral immunity. So finally there is a profound immunodeficiency in them. So first, what is the testing and diagnosis of HIV? First step is towards, see, if female got HIV, first the thing is PPTCT. PPTCT is the thing. What is PPTCT? Prevention of parent to child transmission or prevention of vertical transmission. Okay, this is the main thing. And basically, the test which we are doing now, it is for both P24, that is core protein antibody, and GP41, that is envelope glycoprotein. Okay, P24 and GP41. 41 is aged. Then, yeah. See, if one kit is positive now, do two more kits, second and third. If both A1, A2, matlab kit numbers are A1, A2, A3. If A1, A2, A3 is positive, then she is positive. If A2 and A3 is negative and A1 is only positive, then the result is negative. If in A2 and A3, if one is negative, one is positive, then you should say that that is indeterminate report. You'll repeat the test after 14 days. Okay. Once we got a hepatitis C positive indeterminate patient. Okay, she was posted for surgery. I was on the night duty, so maybe we should cancel her case and we should have been repeated sample. Anyhow, diagnosis in infants and children. Mm, yeah, the pregnant female delivered an infant. She is HIV positive, so infant should be tested. Like dried blood sample should be tested. It should be repeated at 6 weeks, it should be repeated at 6 months. If she's breastfeeding, then after completion of the breastfeeding, after stopping, for example, if she's breastfed for 1.5 years and she stopped breastfeeding now. So after 3 months of completion of breastfeeding, you should test again, or else 18 months of age, like if it is 1.5 years exactly, then also whatever later, you will test again once the PCR test. Which test? PCR test. Mm, 90% children are getting HIV because of MTCT, mother to child transmission. So, coming to goals and objectives of PPTCT, there is 90 is to 90 is to 90 goal. Okay, this is thing is you should detect more than 90% of HIV infected pregnant women. Okay, and more than 90% of detected pregnant women should have this PPTCT services, and more than 90%, we should say that early infant diagnosis is access should be given to them. Okay, they should adhere to the ART prophylaxis. Then in TCT service in India, there is an opt-out option. Like if the lady says I doesn't want to get HIV tested, then you should say no. You should not test her if she say no. Okay. And lifelong ART should be given and breastfeeding women, irrespective of any. If CD4 count is very good or clinical changes improving, then also ART should be continued lifelong. And she should get care for STD, TB, opportunistic infections. Minimum 6 weeks of ARV prophylaxis per birth is given. Okay, community follow-up is very important. Mm, what is HEI? HIV exposed infants. Okay, like the people who are exclusively breastfed should have this early infant diagnosis in this. Okay, after delivery also 6 weeks ARV prophylaxis is given. I told you 6 months, 12 months, 6 weekly after season after breastfeeding should test. Even these infants at 6 weeks of age should get 4 times with prophylaxis. Uh, these infants should have that growth, nutrition, immunization care. Mhm. Cesarean section is only for obstetric indication. Yeah. Main topic of discussion is ART therapies. So ART is generally people say is that see I'm telling about non-pregnant and normal HIV positive patients. What is the ART? No, it is in the pregnant also. Okay. So pregnant patients and HIV. So here NACO says that two NRTI and one NNRTI should be given. What is NRTI? Nucleoside is a reverse transcriptase inhibitors. Nucleoside reverse transcriptase inhibitors. It is lamivudine 300. Lamivudine 300. Another NRTI that is tenofovir 300. So NRTI is 300. Okay. Coming to NNRTIs, that is nevirapine, it is 200. It is NNRTI, na? So 100 less. So it is 200. Then low protease inhibitors like ritonavir is 600. Ritonavir is 600. Okay. Rita is 600. I remember like that. Then Dolu, Dole's that one, 50 rupees you'll give to that person. So dolutegravir is 50. Okay. So I remember this one. Pregnant and breastfeeding with HIV, then you give TLD, that is tenofovir, lamivudine, dolut. You remember tenofovir, what is the dose? 300. Lamivudine, what is the dose? 300. Dolu percent ko which one? 50. So 300, 350. That's it. Okay. Yeah, बहुत ज़्यादा दे दिया यार. Then management of patients who have diagnosed in labor. Yeah, they are. Um, remember the mode of deliveries. NACO says that there is no need of cesarean section. BHIVA, that is British HIV Association. This says that this is very important. This is very easy, in fact, bonus. So, if the viral load is less than 50, then go for vaginal delivery. If viral load is 50 to 300 and 50 to 300, then you'll offer her that cesarean section. If 400, then chup chap cesarean section. Okay. ACOG says that if viral load copies are more than 1000, then you'll counsel her for cesarean section, and she should receive IV zerovodin ideally 3 hours preoperatively as a 1 hour IV loading dose of 2 milligram, followed by infusion over 2 hours until delivery. You understood? Yeah. If more than 1000, you go for cesarean. Before cesarean, you'll give IV zerovodin, Zudio, Zudio. Okay. Zudo that you'll give 3 hours preoperatively, 2 milligram per kg body weight for 1 hour. Then for 1 hour you'll give 2 milligram per kg body weight. For 2 hours you'll give 1 milligram per kg body weight per hour. Okay. Hope you remember this till the exam. Mm, yeah, I just tell about this infants born to HIV, what you'll do. Infants born to the mother of less than 1000, syrup nevirapine or syrup Zudio, where the nevirapine is not effective, is given. If the mother, she's taking protease inhibitor, say one example of protease inhibitor, let another. What is Rita dose? Rita dose 600. Yes, okay. So Rita dose is 600. So protease inhibitor, if she's taking due to based on ART due to treatment failure, then the nevirapine is not effective. Oh, you understood? So nevirapine is not effective in these conditions. If she's taking Rita, then it is not effective. Okay. Infants born to the mother who received single dose of nevirapine during early pregnancy. Only she's not taking any TLD drug. Only nevirapine she took and she came. Then also nevirapine syrup is not effective for the babies. Oh, infants born to the mother with HIV-2 or HIV-1 and 2 combined infection. Okay, HIV-2 or HIV-1 and 2, then also nevirapine based. Then duration is from birth till 6 weeks of age you'll give. Okay. So I used to get confused because many books used to give zerovitin syrup, some books used to give nevirapine syrup. So basically, Better go for Zudo wooden. Zudo is best. Tata is best. Okay. Tata is best. Tata is for even previous cesarean section. Tata is for also babies. Okay. Coming to high risk infants, infants born to the HIV positive mother not on ART, while no not done even once. Mothers newly diagnosed HIV within 6 weeks of delivery. Options of dual ARV prophylaxis is given. In these patients, in this high risk, we'll give Nivi and Zudio, both. In case of exclusive replacement feeding from birth till 6 weeks, should go for exclusive replacement feeding. Okay, that's it. You can write this. Some more other points you can write. Okay, come on. Thank you.